Now we introduce the topic of cell adaptation. Now, speaking about the subtypes of adaptation, there are subtypes like atrophy, hypertrophy, hyperplasia, and metaplasia. So, starting with atrophy, atrophy is a decrease in number of cells along with the decrease in the size of cells. So, atrophy can be both physiological as well as pathological. So, physiological examples include atrophy of the notochord or atrophy of the ductus arteriosus. Now, the ductus arteriosus is that structure which is present in the fetal life and is not required after the baby is born, so the cells get destroyed. So, this is a physiological example of atrophy. Now, moving on to the pathological examples, these include malnutritions, namely kwashiorkor and marasmus. It also includes nerve injury. We can take the example of poliomyelitis over here, where there is interference of the activity of the anterior horn cell of the spinal cord. So, if the anterior horn cell of the spinal cord has interference, what will happen is that the skeletal muscles which are supplied from this area, particularly the lower limb muscles, are going to be affected. Thus, atrophy is seen over here. So, you can see that the clinical manifestations of the patients with poliomyelitis is going to be seen in the form of limping, or the patients will have a limp. Now, moving on to hypertrophy. Hypertrophy is the increase of size of the cells due to oversynthesis of structural protein. Now, this can be also categorized as physiological and pathological both. Now, physiological example has a classic example of pregnancy. Now, in pregnancy, the size of the cells of uterus as well as the breast increase. There is also example of puberty, and there is also example of muscle hypertrophy. Like, for example, if you are a bodybuilder or if you go to the gym and you lift heavy weights, now you are putting stress on the skeletal muscle fibers. Now, as we know that the skeletal muscle fibers are permanent cells, right, which can't divide. So they have to bear the stress by some way or the other, so they adapt and they grow in size and not replicating. So this adaptation is the physiological hypertrophy. So moving on to pathological hypertrophy, the classic example will be of a cardiac patient, particularly having hypertension. So in the case of hypertension, we know that there is extra pressure of blood in the systemic vessels, right? So if there is extra pressure in the systemic vessels, the left ventricle will generate more and more force so that the blood pushes out of the left ventricle. So if this continues for a long time, gradually the patients will have left ventricular hypertrophy. So if the question comes that the cardiac patient having hypertension, what can be seen? You can obviously say there will be left ventricular hypertrophy. So linking this with pharmacology, we know that the microsomes are responsible for drug metabolism, right? So if there is microsomal hypertrophy, like if the microsomes undergo hypertrophy, then the drug metabolism will obviously get faster, right? Because there is hypertrophy, so the functions will also be increased. So the drug metabolism will get faster or boosted. Now there is an anti-epileptic drug which causes microsomal hypertrophy, and that is known as phenobarbital. Remember, phenobarbital is an anti-epileptic drug which causes microsomal hypertrophy. So if a patient is undergoing treatment with phenobarbital and there is microsomal hypertrophy, so if he is given other drugs as well, so the drug metabolism of the other drugs will get boosted as well. So that should be kept in mind. Now the points to remember about phenobarbital. Phenobarbital is generally safe in pregnant patients. So if there is an epileptic patient who is pregnant, so phenobarbital can be given in this case for the treatment. And phenobarbital also causes CNS depression in adults. And the another point I want to emphasize upon is phenobarbital cause paradoxical excitation in some pediatric cases. So in some small children, there can be cause of paradoxical excitation as well. Now moving on to the other topic of cell adaptation, which is hyperplasia. Now hyperplasia is nothing but the increase in the number of cells. Hypertrophy was the cell size and hyperplasia is the number of cells which is getting increased. So this again has both physiological and pathological aspects. So the physiological aspect is going to be pregnancy. Now over here I want you to remember that uterus size increases by increase in the size of cell as well as number. So over here this uterus is going to be called as gravid uterus, where we can see both hypertrophy and hyperplasia as well. So this is an important point to remember. Questions can come from this point. And another physiological example may be puberty. Now the common pathological example can be of endometrial hyperplasia. Now endometrial hyperplasia is a precancerous condition as well, which you need to remember. So if a patient comes to you with endometrial hyperplasia, it is always a cause of worry because it can be a precancerous condition. So the patient might require routine follow-up so that it can be recognized early if malignancy occurs. Another pathological common example is benign prostatic hyperplasia, BPH. Now, let me tell you, benign prostatic hyperplasia is not a risk factor for development of malignancy because the name tells that benign prostatic hyperplasia. So the benign term is there, so there is no chance of malignancy. So considering benign prostatic hyperplasia, we need to keep in mind a few points. Now the first point is that the hormone responsible for BPH is DHT or dihydrotestosterone, but not testosterone. There is a common mistake that many students write that BPH normally occurs for testosterone, but it is dihydrotestosterone. Dihydrotestosterone is obtained when 5-alpha reductase converts testosterone to DHT. Now over here I want to link with pharmacology once again. So the treatment of BPH can be done with a drug called Finasteride. Now what is Finasteride? Finasteride is basically a 5-alpha reductase inhibitor. So if someone is having benign prostatic hyperplasia and there is a problem in micturition or there is painful micturition because the prostates are enlarged, so you can treat that patient with Finasteride. So the 5-alpha reductase will be inhibited and thus the formation of DTH will decrease and thus the inflammation will subside gradually. Now DHT is also responsible for androgenic alopecia in young males, which shows an anterolateral pattern baldness. So if there is androgenic alopecia, you can also consider using Finasteride for the treatment. So the last cell adaptation which I'm going to talk about is going to be metaplasia. Metaplasia is the change in the type of cell. So if there is an adaptation where the cell type is changing, it is going to be metaplasia. Now let me tell you the mechanism. There are normally stem cells present in our body and the stem cells get divided into epithelial or mesenchymal cells. So if this gets affected due to any injury or injury causing agents, so then we can see the formation of metaplasia. So there are two types of metaplasia, namely epithelial metaplasia and connective tissue metaplasia. Now you need to remember a few points regarding metaplasia which can come in the examination. So first is regarding the lungs. So the lung normally has pseudostratified ciliated columnar epithelium, right? So if a person who has a history of smoking for a long period of time, you can observe that smoking changes the pseudostratified ciliated columnar epithelium to squamous epithelium because it gets exposed to the toxins. So this is an important point. So the change of pseudostratified ciliated columnar epithelium to squamous epithelium should be remembered, which happens to the lungs due to smoking. Now the second point you need to remember is of Myositis Ossificance. So if a patient undergoes trauma, there will be the formation of hematoma. So when that hematoma will subside, there will be calcification occurring, and thus there will be a hard muscle formation which resembles bony like structure, which is normally known as Myositis Ossificans. And you also need to remember that this is an example of connective tissue metaplasia. And the third point which you need to remember is about Barrett Esophagus. Barrett's esophagus is a very common question, and normally it comes in exam a lot of times. So just remember these few points, that during Barrett's esophagus we generally tend to see a dual lining of esophagus. So in Barrett's esophagus we know that the lower part of the esophagus gets exposed to the acid due to gastroesophageal reflux disease. So the upper part has stratified squamous non-keratinized epithelium. So the lower part which gets exposed to the acid gets converted into intestinal columnar epithelium. So this is an example of intestinal columnar epithelium metaplasia. So if the question comes like what is an example of intestinal columnar epithelium metaplasia, you need to mark the option as Barrett's esophagus. So the dual lining of Barrett's esophagus, the top part is stratified squamous non-keratinized epithelium and the lower part will be of intestinal columnar epithelium.